Heads up, healthcare professionals, it's time to book your place. MIMS Learning Live North is returning to Liverpool on Wednesday the 26th of November. This year we're heading to a brand new venue, Spaces at the Spine, owned by the Royal College of Physicians, with panoramic views of the city. Brought to you by MIMS Learning, this leading primary care event in the UK offers 3 educational streams led by experts. This means 6 CPD hours of learning on topics of your choice across the day, with an additional stream dedicated to how to better run a practice and the 10-year plan. This is an event you'll not want to miss. Spots will go fast, so don't wait. Head to mimslearninglive.com/north and register today.
Hello and welcome to the Clinical Update podcast, the podcast that brings you thought-provoking clinical education from MIMS Learning that you can fit into your busy life. I'm Sangeeta Krishnan, medical editor at MIMS Learning. Today I have with me fellow medical editor Dawn Powell.
Hi.
So today I wanted to talk about the conditions that, though they are fairly common, can pose a greater risk to pregnant women than the normal population unless managed proactively.
Okay, so we're talking about things like hypertension and diabetes. What about infections such as chickenpox and measles? I mean, I know these tend to be self-limiting in children, but they are more of a concern in pregnant women.
That's right. Our colleagues Pat and Rhiannon actually spoke about those infections in one of our previous episodes. And given that we've recently published some content on thyroid disorders and hypertension in the antenatal period and in pregnancy on MIMS Learning, I'd like to focus on these for this episode. So let's start with the thyroid. Managing disorders of the thyroid gland, particularly hypothyroidism, is a lifelong balancing act of getting that TSH just right. This balance changes dramatically when you add pregnancy to the mix.
Yeah, and so I think the key is understanding how pregnancy, or rather trying to become pregnant, affects the management of thyroid conditions. So just to recap, normal free T4 and a TSH between 5 and 10 milli-international units per litre indicates subclinical hypothyroidism rather than overt hypothyroidism. Treatment of subclinical hypothyroidism in someone who isn't pregnant is case by case, with watchful waiting being okay for some patients.
So, according to the British Thyroid Foundation, GPs generally adopt this wait-and-see approach, like you said, and don't treat patients who have slightly elevated TSH levels, because studies have shown that over half of these mildly elevated TSH readings will normalize spontaneously within a year.
Okay, but if somebody is pregnant or they are actively trying to become pregnant, then treatment of subclinical hypothyroidism is important. In our webinar on understanding and managing thyroid disease and fertility of pregnancy, consultant gynecologist Dr. Rima Dillon-Smith says that subclinical hypothyroidism would definitely need management with levothyroxine in a woman who is pregnant and is trying to conceive. But can we just go over why that's important?
Yeah, so the developing fetus relies entirely on the mother's thyroxine during the first trimester before its own thyroid gland is fully functional. So any inadequate maternal thyroxine during this critical window is linked to a higher incidence of things like pre-eclampsia, preterm birth, miscarriage, and potential impaired neurocognitive development in the child. And in patients who have overt hypothyroidism, again, the thyroid will not be able to cope with this increased demand in pregnancy, and it translates to an increased thyroxine demand of about 30%.
Okay, so you've got a pregnant person, they've either got overt hypothyroidism or subclinical hypothyroidism. What is the recommended target for the TSH level in someone who is pregnant or is trying to conceive and needs some sort of thyroid treatment?
So according to the RCOG guidelines on thyroid and pregnancy that came out earlier this year, if a woman is pregnant or if she's trying to conceive, regardless of whether her hypothyroidism is overt or subclinical, then she will need medication to bring the TSH down to below 2.5.
Okay, so how does pregnancy affect the treatments of hypothyroidism? Like, how does that affect the drug?
So in a person who is already receiving levothyroxine, clinicians will need to initiate an empirical increase in their levothyroxine as soon as they have a positive pregnancy test. So according to Dr. Dylan Smith, an easy way to do this for a pregnant woman who is already on levothyroxine is by doubling the dose on 2 days of the week. So, for example, if a patient's on a daily dose of 50 micrograms, she can be told to continue her usual dose and then take double that, that is 100 micrograms on Saturday and then again on Sunday.
Okay, so that's a practical step for primary care to know. Increasing the dose preempts the increased physiological demand on the thyroid gland when someone becomes pregnant. Speaking of levothyroxine, are there any drug interactions that patients should be made aware of?
Yeah, there are plenty. Studies have shown that levothyroxine interacts with coffee, soy products, fiber, calcium, or iron. All of these impair absorption of the hormone. Patients need to be counseled to take levothyroxine on an empty stomach, allowing a window between these foods and the medication to avoid the risk of malabsorption.
Okay, so just a note about overt hypothyroidism. If left untreated, it also is associated with increased risks during pregnancy, such as pre-eclampsia, preterm birth, fetal growth restriction, and maternal heart failure. We are going to come back to thyroid disorders later because we need to look at the effects of medication during pregnancy. But for now, let's move on to discuss another condition in pregnancy, gestational diabetes. Maternal diabetes, if uncontrolled, particularly in the first trimester, can significantly increase the risk of preeclampsia. When HbA1c is expressed as a percentage, every 1% increment in the first trimester can increase the risk of preeclampsia by as much as 60%. So obviously, managing glucose is a very important consideration in someone who is pregnant.
Absolutely, and it's all interconnected. Tight glycemic control, particularly before conception, is pretty crucial for those with pre-existing diabetes. But for now, let's move on to discussing hypertensive disorders of pregnancy. Pre-eclampsia is obviously a major concern, but there are other forms of hypertensive disorders like chronic hypertension and gestational hypertension. And let's not forget white coat hypertension, that classic scenario where a person's blood pressure spikes when they're in the clinic, but it's completely normal at home. Even though it's usually benign, in pregnancy, white coat hypertension can signal a high risk of developing true preeclampsia later on.
You were just talking about gestational hypertension there. Can you just give a quick definition of it?
Yes, so according to our Practice on a Page module on hypertensive disorders of pregnancy, a blood pressure of 140/90 or more on 2 occasions taken at least 4 hours apart after 20 weeks of gestation in a woman whose BP was normal before and without features suggestive of preeclampsia is defined as gestational hypertension. So to treat pregnant women with hypertension, the module advises aiming for a target clinical BP of less than 135/85. Studies have shown that this is associated with better pregnancy outcomes than when treating only those with severe hypertension. This is in line with our national guidelines on treating hypertensive disorders of pregnancy.
Okay, just going back to preeclampsia, what are the signs of preeclampsia?
Discussing the signs of preeclampsia take me back to the last month in my first pregnancy, which came back with a preeclampsia scare. I did have hypertension, but thankfully it didn't turn out to be preeclampsia. So anyway, the signs of preeclampsia include severe headache, pulmonary edema, epigastric pain, visual disturbance, sudden swelling of the face, hands, or feet. Preeclampsia can lead to pretty serious complications and it can progress to eclampsia, which is a life-threatening condition. And so treatment involves careful monitoring and potentially considering an early induction of labor.
The risk factors for preeclampsia include a first pregnancy, which would tie in with what you were just saying, Sangeeta, about your experience, a maternal age of 40 years or older, having a gap of 10 years between pregnancies, and a family history. And just to mention, our Practice on the Page module on hypertensive disorders of pregnancy has all of this information on a very handy printable format.
And similar to the risk factors of preeclampsia, the risk factors for hypertension include nulliparity, a maternal age of over 35 years, Black or Hispanic ethnicity, obesity, small for gestational age, and the presence of type 1 diabetes or migraine in the mother.
Okay, so that's the risk factors for pre-eclampsia and the risk factors for hypertension. If you suspect pre-eclampsia, proteinuria should be excluded. The module advises avoiding testing the first morning urine sample. The diagnostic threshold for proteinuria is an ACR of 8 milligrams per millimole. When the blood pressure is 140/90 or higher and there is proteinuria, the patient needs to be referred onwards to secondary care.
Yeah, so pre-eclampsia is managed in secondary care. And to manage hypertension, clinicians can offer lifestyle advice like diet and exercise and low salt intake. Treatment is with low-dose aspirin, 75 or 150 milligrams, from 12 weeks of gestation. Clinicians should aim for a clinical blood pressure of below 135/85. Labetalol can be given twice daily. Dawn, are there any other antihypertensive medications indicated for this?
While there aren't any other drugs indicated, nifedipine and methyl-levodopa are often given off-label to manage hypertension in pregnancy. But very important to know that ACE inhibitors, or ARBs, and thiazides are associated with increased risk of congenital abnormalities, so these treatments should be avoided. As you mentioned, women who have pre-eclampsia should be referred to a critical care setting.
Yeah, well, it's true that ACE inhibitors are not advised during pregnancy. Postnatally, when there is the 6-week review, if the patient still has hypertension, the ACE inhibitor enalapril may be offered. Nifedipine or amlodipine might be considered for Black African or Caribbean women, and combination therapy may also be offered as needed.
Okay, so what about if the woman is breastfeeding? How will these medications affect the breast milk?
According to NICE, the levels of antihypertensive medicines that make it into breast milk are so low that they would be unlikely to have any clinical effects. So Dawn, you mentioned the risk of congenital abnormalities with some of the antihypertensive medications. So shall we talk about some of the risks with anti-thyroid medications?
Yeah, so pterogenicity risk is always a major clinical consideration. Nobody wants to see what happened with thalidomide again. But specifically, with thyroid conditions, the RCOG guidelines that you mentioned, Sangeeta, do discuss the risks associated with the drugs used to maintain thyroid status in pregnant women, and states that some of these drugs are associated with the possible risk of placenta abruption. And carbimazole, which is used for hypothyroidism, has been associated with an increased risk of congenital abnormalities compared with propylthiouracil. However, the latter has also been linked to birth defects, although these are thought to be less severe and potentially resolvable. So, given these risks, what do the guidelines actually recommend?
So, the guidelines recommend propylthiouracil pre-conception and in early pregnancy. If a woman with pre-existing hyperthyroidism is on carbimazole and conceives, the RCOG recommends switching to propylthiouracil, ideally immediately upon confirming pregnancy and definitely before 10 weeks gestation. Women will often need a reducing dose of anti-thyroid medication as their pregnancy progresses, and treatment can be discontinued in most cases in the late second or early third trimester of pregnancy. If treatment is still needed beyond 20 weeks, the patient may be switched to carbimazole due to the associated liver toxicity with propylthiouracil. So, are there any other considerations postnatally for women requiring medication for their thyroid, Dawn?
Going back to hypothyroidism, levothyroxine is relatively safe. But for women with hyperthyroidism, both of the drugs we've been mentioning are considered okay for breastfeeding when used at the lowest effective dose. Only a small amount of the drug transfers into the milk, and this is typically not enough to affect the infant's thyroid function. Okay, just to recap, in a woman who has hyperthyroidism and is pregnant, there needs to be a careful review of the medication she is taking, as that may need to change depending on what medication it is and how far along she is in the pregnancy.
Yeah, and so it is really valuable for GPs to know this information when counseling women with hypothyroidism who are planning a pregnancy or are in the early stages of one. It's all about trying to minimize the risks and maximize benefits with these anti-thyroid drugs. So, what have we learned today? For women who are pregnant or trying to conceive, the TSH target should be at or below 2.5 milli-international units per liter. There is a roughly 30% increased thyroxine demand during pregnancy. In patients with known hypothyroidism, this can be met by doubling the dose for 2 days of the week. Features of pre-eclampsia include severe headaches, pulmonary edema, epigastric pain, visual disturbances, sudden swelling of the face, hands, or feet, and these warrant immediate referral. Pharmacological choices for hypothyroidism in pregnancy are trimester dependent. Propylthiouracil is the preferred medication in the first trimester due to its lower teratogenicity risk, but may be switched to carbimazole later on due to the maternal hepatotoxicity risk with propylthiouracil. Thanks for joining me in this discussion, Dawn. Don't forget that you can claim CPD credits for listening to this podcast. To get your certificate along with key learning points, you just need to go to our website, mimslearning.co.uk. You've been listening to the MIMS Learning Clinical Update podcast produced by Jude Owen. We hope you'll join us again next week when Rhiannon Ashman speaks to pancreatic cancer nurse specialist Rachel Richardson. See you next time.